Hi, everybody. My name's Tom Krazit. I'm a reporter with CNETnews.com. I'm pitch hitting for Michael Copeland, who couldn't be here today. But I'm sitting here with Bill Haseltine, who's going to take us through a discussion of healthcare in the 21st century and how biotechnology and healthcare are all sort of coming together at this point. Just to give you a little background on Bill, has got a PhD in biophysics and was a professor at Harvard Medical School, has founded no less than 10 biotechnology companies, including one called Human Genome Sciences, and is currently president of the Haseltine Foundation, and he says his number one goal is to improve healthcare and services worldwide. And so the gist of our talk this morning is supposed to be about costs, and I don't think it's a shock to anyone out there that healthcare in this country is enormously expensive. So how did we get there? I mean, why don't we start with that?
Well, we've built a system which the relationship between those who pay and those who benefit is separated. I think if there's any market in which you have such great separations, you'll have great cost inefficiencies. The benefit that occurs is either to you individually or to society as a whole. But it's completely separated from who pays. And so the whole system that we've built is designed to extract the most money from the payers, and that's the system we've built.
Is that the way it's always been? I mean, is this a more recent phenomenon?
No, it used to be people paid for services themselves directly without insurance. It's hard to imagine a world without insurance where you have shared collective risk. On the other hand, it's very hard to see how we can get from where we are to where we need to be. But let me say, what I've been mostly focusing on is not how to pay for the system. What I've been looking at from a number of different perspectives is what it is that we're paying for. If you look at the current debates, you very rarely hear, if ever, in the current great political debate about healthcare, as to what it is we're paying for. Basically, it's how to pay for it. Whether the federal government should pay for it, the state's government should pay for it, how much you should pay for it. But it isn't what we're paying for. And what we have is a system which is enormously inefficient. I recognize that from a technology point of view because what I was being told is every time we created a new wonderful technology through the results of application of cutting-edge science, it was costing the health system more. And people are getting more and more resistant to that. And I'm fearful that all this wonderful knowledge that we're creating through genomics, through proteomics, through use of new information tools to understand the living system isn't going to benefit us if we don't get our costs down. Where we're headed for in America right now is a system of health rationing. I live in Washington and New York, and I see both the financial pressures and I see the political pressures. And the net result, I think, is right now we're putting in place, unseen by most of us, a system of serious health rationing. So very new costly procedures won't be paid for by the government, then they won't be paid for by insurance.
Let's talk a little bit about that, the relationship between which the private insurers rely on sort of the government to set the standard for what
They do
will
set
be
the
covered.
standards. And if the government pays for it, health insurance is more or less obligated to pay for it at more or less the same cost. And if private, and that's basically how it works. And if they decide not to pay for something, it's not going to be paid for by insurance. So what I did a few years ago is start looking around the world, hopefully for places that had more efficient health services. And I found very efficient health services in a place you might at first think was unlikely, and that's India. Now, most of us have heard about health tourism, and that's not what I'm talking about. I'm not talking about you going to India to get a heart operation in a hospital that's more or less like an American hospital, and they have lower labor costs, lower land costs, lower equipment costs, so your net cost is lower. That is not what I'm talking about. I'm talking about a system that delivers high-quality health to middle-class Indians that has an outreach for the poor, that subsidizes the poor, and that takes our modern technology, reprocesses it into a system of great efficiencies. I found several groups that were doing that. These are typically people who'd worked for the government, healthcare services, couldn't stand what they were doing, set up their own private services in a number of different specialties, and some of these are now large multi-specialty hospitals. and deliver high-quality health care using Western technologies to their maximum, or at least a high efficiency. And if we did what they did here, we would probably save about 80% of our healthcare costs. We could reduce healthcare services. Let me just give you one or two examples. Let's take heart surgery. How can you make heart surgery more efficient? One way is to have doctors who do heart surgery do more surgeries. They do, on average, in the hospitals I'm talking about, and these are multiple hospitals, not just one, 10 times as many heart surgeries. The outcomes are better because they have more practice. How do they do that? Well, they have a system which you would put in place if you were trying to design an efficient system, in which teams of doctors go from place to place. One team opens up the patient, other teams do some part of the operation, others do others. The net result is they do 10 times more operations. They also use slightly different procedures. They have trained their surgeons to a higher level, so they operate on a beating heart, not a stopped heart. Much better for the patient. So 70% of their bypass surgeries are done on open hearts that are still beating, on hearts that are beating. That takes better surgery, but is better for the patient because you don't get what's called bubble brain from the heart lung machines. In another field, eye surgery, the way they do 50 to 60 operations a day is they have 2 beds. The surgeon first does one. While he's working on this bed, they're changing the patient out and preparing him. He turns around and he does the other. Those outcomes are far better. The average cost of their heart surgery, their bypass surgery, the real cost of them, including all the materials and labor, is about $1,500. They will charge $2,000 for those heart operations. The average cost of a cataract operation, including all the materials which they manufacture, is about $40. There's one hospital that's been set up to do eye surgeries that now does about $300,000 a year. Average cost of a cataract, as I mentioned, surgery is $40. They are quite profitable as a not-for-profit. They use that to build other hospital systems. And there are many, many examples of that.
Does this have any impact on how patient care is delivered? Do you have to wait longer to receive these services? Or?
You can't wait very long. They actually have a system worked out. And it's a whole process. And what I'm trying to do in India now is I'm working with 1 or 2 of these hospitals and building them up to critical mass so that we can then use them as proof of concept examples that this system works, and then working on interfaces to try to get these systems exported to other countries. The process that they also use a lot of different personnel processes. So that just like in a US military system of active duty personnel, they use medical corpsmen. These are people who are high school graduates. They have nurse practitioners. They spare their doctors, which are in limited number, for what a doctor actually has to do, which is a surgical procedure, a judgment of what kind of care to give. Since one of the focuses of this meeting is on emergency responses, let me tell you about a system that's recently been put in place in central India. They didn't have a 911 number. It just didn't exist. Satyam Computer, which some of you may know, is one of the big outsourcing computer companies. Ramalinga Raju, who's the head of that, decided that they should put in a 911 equivalent. It's 108 there. He has a foundation, and he put in, I guess, about 20 or 30 million of his own dollars, plus a lot of his people's time. Now, they build call centers for everybody. Many of the systems that we use here, they've built. So it isn't that they're not at the advanced technology level. They put a single call center in for emergency response with police, fire, and medicine for the state of Andhra Pradesh. They began about 3 years ago. They work with Stanford for the high quality. They work with McKinsey for management systems. It's now not quite 3 years later. They have a system which provides emergency ambulance service to anybody in the state within 20 minutes. Now, many of you have been to India, and you know that the roads aren't exactly great. Andhra Pradesh is a big state. It has 80 million people in it. There's an ambulance within 20 minutes of anybody in that state. Mountain regions, slum regions, city regions, in that horrible traffic. Well, how do they do that? They use the most advanced systems for information. A call comes in, they know where it is. They know where their ambulances are. They have a research unit that does hour by hour, minute by minute optimization of how to use their resources. They've worked with Stanford and others to build robust ambulance services. From the time the call comes in, there's a dispatcher which routes with real-time GPS and traffic information, turn by turn, the driver to the patient. A doctor's on the phone with a patient, with the emergency tech in the ambulance to bring them there. They've just set up a new system. We were talking about, just earlier you heard, health services over the phone. They have created a new service. The first one was called EMRI. This one is called HMRI, where they have got now, by the end of the year, they'll have 400 doctors and 2,000 med techs available for citizens of Andhra Pradesh by phone to diagnose and prescribe. They have voice prints linked to phone numbers for authorized prescribe, people can dispense medicines. It's a really interesting system. Now, it's also a really interesting system of a public-private partnership. The Indians know that they're corrupt. It is not a surprise to them that they're corrupt. They know that. They also know that if you try to run things through state systems, they don't necessarily work very well. So they're beginning to experiment with public-private partnerships. This is a foundation which manages and pays for the top professionals. They then have the sole authority to hire and fire people. But in Andhra Pradesh, this ambulance service is now paid for 95% by the state. It's been so successful, it was adopted by Gujarat now, which is functioning with 55 million people, and the Indian government now has, by the end of this year, asked them to do the same for 10 other states, and by 2012 for all of India. What's interesting for us here is that they've now teamed up with Cisco to deliver this service globally. If we wanted to, for say California, which is not 80 million people, it is not the size of Andhra Pradesh, we could set up one call service in California, and McKinsey estimates if we did it the way they do it in Andhra Pradesh, California would save 200 times its expenses in emergency services, 200 times.
What's preventing this kind of system from taking hold here?
I think there are a lot of things that are preventing it, and you could probably name them as well as I can. Okay, self-interest, vested interest, medical professionals. There's a whole series of things. My goal through my foundation and others, and fortunately we've just been joined by the Rockefeller Foundation to look at health systems in India, private health systems. There's now a realization that as much money as goes into research, as great as the Gates Foundation is in creating new solutions, there's a problem. Some people call it delivery. Some people call it implementation. The new name for it is systems, medical systems or healthcare systems. There's a real problem how you actually get that extra mile. Where I think a lot of it is being created is in India through these systems. And what's great about them is they're now willing to export them. There's an export unit that a state, a country can access, and they will provide these services. That's for these emergency services. I would like to see that happen for some of these hospital systems that are not geared for the wealthy of the world, that are geared for the middle class, that can deliver a middle class service. Let me go back and make one other point about heart surgery. If you look at the total cost of heart surgery in the US, it's about 2 or 3 times your an average annual salary. In Hyderabad, through their system and other systems in other cities in India, it's about 1/3 of a middle class annual salary. And I think that's a fair comparison. That's sort of like the McDonald's burger unit of comparison. I think it's a really fair comparison of what costs can be. And it tells you that you can get a lot more efficiency. What is going to happen in this country? Are we going to go to a system where we ration increasingly what you can get, and it's the federal government that will do that by setting what they will pay for? I'm at the Brookings Institute, among other things. I'm on their board there, and we have a healthcare policy group. And I can tell you what they are looking at, and what a lot of the government apparatus here in your country is looking at, is rationing your services. They call it all sorts of things. In Great Britain, they have something called NICE. NICE, if you're a patient, is anything but nice. because what it does is it determines the cost-benefit ratio of a new procedure. So they let drugs get approved, they then do a cost-benefit analysis, and if they don't like it, you don't get it. And that's increasingly the case for a lot of the new biotechnology drugs, a lot of the new and effective costly procedures. They, and whoever they is, decides it's not in the state or whoever is paying benefit to do so. I think that's coming here. I know it's coming here.
How can systems improve the efficiency of that leg of the healthcare
well,
system?
Well, if you can, where is the cost in healthcare? It's in services. Now, services, healthcare services, is a really big nut. It's getting to be such a big nut that the U.S. military, when they do forward planning for major strategic threats, have now identified the major strategic threat to the security of the United States as rising internal healthcare costs. Why? Because those costs will eat up so much of the federal budget beyond 2015 that it will begin to seriously impact military spending. And that, by the way, is true for infrastructure, for education, for many other things. It's our major number one security threat, external or internal, is our healthcare threats. So we are either going to control it by rationing, or we can control it by improved efficiencies.
How will these efficiencies be implemented? I mean, do you have any sense that, the political leaders of this country are taking that threat seriously at this point in time, or is it just putting it off for the
My actual belief is that I have a belief and a hope. My belief is things are going to get a lot worse before they get better. That it isn't until people begin to really scream about the quality of their health care. What's happening to you and I right now, or you and me right now, is that we're paying more and more, even though we pay a hell of a lot for insurance. So what I experience is I'm paying more for my insurance every year, and I'm paying more out of pocket every year. And at some point, that becomes unbearable for most people. They can't do both. But that's actually what's happening. So they don't buy either health insurance as much, or they don't pay out of pocket as much, and they don't get the health delivered. That's the way it's happening. Until people realize that there's another way to do it, and intelligent businessmen come up with better ways to do things and say, look, here, I've got a service that's going to provide you a high-quality service like the guys in India. I'm going to model it, adapt it for the American circumstance, because we're not going to do all the things they do. If you walk into those hospitals, let me guarantee you, you're not going to be a happy camper. You might come out healthy, but you won't be happy through that process. We're not going to tolerate some of the things they tolerate in these hospitals. The crowding, the chaotic conditions, we're just not going to tolerate that. But you can take a number of their management practices and move them here effectively. And I think there is an enormous business to be made by delivering a high-quality hospital experience that's really efficient.
Will the same sort of public-private partnership work in this country to the extent that it has in India?
For the emergency services and these call service networks, I think we heard earlier from the first person in the last panel that there's now an effort to do telemedicine. That probably will work, and it will work in a different kind of context. If I understood that properly, that was entirely insurance-based. And I can assure you that every insurer is trying to look at how to improve through technology their payments. They want to lower their payments by keeping you healthier. That's a very good thing. We have the insurance companies now trying to keep us healthier. Now, we're pretty resistant to that, but information services can really help that. There are some companies that know people have volunteered to let them see what you buy in their shopping baskets, and they can pretty much predict what your health outcome is going to be by what you buy. They're going to like to have a feedback system to tell you, hey, don't buy that.
I mean, a lot of what we've seen in the consumer technology side, I've been covering companies like Intel and IBM as they've tried to tackle this problem. And a lot of the solutions that they have are inherently technology-based. You know,
Right.
like the Intel wants to put a monitoring system in the home of every person with some sort of long-term disease or care issue. Are these the types of systems that are needed, or is it more of a back-end thing? I mean,
I think you need to do both. You need to have, and technology has an enormous role to play here. You need, on one hand, to have a tertiary hospital system which handles people who are really sick efficiently. It's got to be cost effective. And that we can reduce our costs enormously. I think we can squeeze certainly 50 and probably 60 to 70% of the cost out of that and get better outcomes by rearranging how we use people, by rearranging systems. It's going to be a painful process because these are all professional groups with their own real power. And by the way, it is the only source of jobs that keeps growing in America, Europe, and Japan, is healthcare services. It's the engine that sort of keeps our economy going and stabilizes us through downturns at this point. And I've talked to, serious government leaders in other countries who say, look, I can't touch healthcare services. I can't reduce those costs. That's my only source of job growth. Our government will be tossed out in a minute because that's where jobs are. That's a really big problem. If you don't have a serious source of jobs other than healthcare services, you're going to have to think about what you're doing. So that's part of the problem. But I think the other part is the use of information services to keep us compliant, to keep us healthy, to keep us in touch with our health all the time. And their information services that reach into the home are very effective. Again, India in some ways is going to be and is the leader in that in a very different way, because what they have is a need to reach out to 700 million people who don't have access to doctors. That's what this system that I mentioned, HMRI, is. It's a very high-tech system. Right now, it's over the phone. You can call in, you get on the line a doctor and a paramedic who tells you what to do. In 90% of the cases, that's sufficient. In the other cases, they tell you where the local specialist is that's closest to you. They're moving that one step forward in their context, which is they now commissioned their first mobile hospitals. They want to cover the entire state at state expense, again through a private partnership with a group of mobile hospitals. That kind of technology that's used on a mass level there can be personalized here.
Let's assume that our leaders decided this was a priority and this was something they wanted to make happen. How long would it take?
First of all, I don't think it's going to be our leaders. I think it's going to be you and me that put pressure on our leaders that say we demand not just that you pay for it, but we get better services.
Okay, well, after they succumb to that pressure.
I think that, let's take Andhra Pradesh. They put their emergency services in place in 2.5 years for 80 million people in a really chaotic environment. And when I'm talking about chaos, I'm not talking about San Diego traffic. I'm talking about something, a good deal worse than San Diego traffic. It worked. It can be done with the right will. The hospital systems will take longer because it takes training. It's a training process of how to get doctors to work in teams. It's a process for how you respect everybody in the whole network. In a way, we have that system that operates. Some people here have been active duty service members and understand what an active duty service healthcare system is. That's the type of system that we need to put in place. Especially now, it's heavy with telemedicine. Many of you may have been providers for some of these services. It's a parallel system which functions really efficiently in the midst of our society, which we don't really pay much attention to. So we have the people and the systems in some ways that could do this, but we need the will. So I would say that if we decided this is the way we wanted to go, we could be there in less than 10 years.
One of the recurring themes from the alternative energy discussions that we've had so far this week has been the issue of scalability.
Mm-hmm.
You know, that there are a lot of technologies that make sense in smaller areas, but can't necessarily scale up to what it would really need to be in order to change the way things are done. So is this scalable? Is this something you can take?
From our experience, I've chosen to work with one hospital. We started 4 years ago with about 500 beds. We now have 2,000 beds. By the end of this year, we'll have 4,000 beds, and we are hoping to have 40,000 beds in 10 years. That's big. If you want to look at things at scale, look at India. Why do I say India? Because China has very different kinds of solutions. They're generally government solutions. They're not generally market-driven solutions. By the way, most of these hospitals I'm talking about, whether they're not-for-profit or for-profit, are profitable. There's a great emphasis on scalability through profit. These aren't organizations that continually soak up Western money. They take virtually no Western money. These eye hospitals that now treat 300,000 people, zero Western money. A little bit of Western technology that somebody mentioned, the Seva Foundation, provided to them for low-cost lens manufacture, low-cost suture manufacture. My hope is eventually, and it's beginning to be realized, that they are producing low-cost materials that we can benefit from. So far, we don't. We sort of have a monopoly, a couple of big medical supply companies that monopolize everything. But they're providing, instead of $80, $200, $2,000 intraocular lenses, they provide them at $4 globally. So they export them to China, they export them to South America, to Africa, to other parts. We don't use them here. We could, but we don't.
Is the need for profit a key component of this, do you think? I mean, you
It
hear
is.
different
I
things
think the
about
need
that.
to be self-sufficient. And I think what we've learned in general in the whole business of helping other countries and helping ourselves, if it's not sustainable through its own profitability, whether it's a not-for-profit and reinvest those in research and reinvest those in other hospitals, or whether it's a system, which is a hospital for-profit system that gives return to its investors, I think it is very important that these be profitable.
Okay. Well, I had wanted to allow a little bit of time for questions since I can't think of an issue that we're discussing at FiRe that affects every single one of us more than healthcare. So, I mean, if there's anybody that has a question, stand up. It's a little hard to see, but we'll try to.
Yes.
It's over there.
I am Preet Banerjee. I happen to be from India. An observation is that the persons who provide those healthcare services in India, their compensation is significantly lower than the US. Do you think the American Medical Association will embrace the concepts that you are proposing?
Let me say, first of all, the compensation relative to other peers in India is not that much less comparatively than doctors here. It is dramatically less. That's why when I was giving that open heart surgery example, I compared it to average income, the cost of the average income. I think there will be enormous resistance. My own belief is, as I said before, things are going to get better before they get worse. They're going to get worse before they get better, if they ever do get better here. I am not particularly optimistic that these high efficiency systems are going to be put in place in the United States in the near future. It's groups like the doctors of this country that have very powerful professional groups. It's the hospital services. I call it actually the lobby for health services, the dirt lobby. It's deeper than the grass. Every tiny community has its health services. And you begin to rearrange, restructure, and cut those services, you have a terrible political problem on your hands. It isn't until most people feel so much pain because of the quality of health services and the cost of their health services that we're going to get a movement where a brilliant company comes up and begins to provide these kinds of services. We will have some high-tech services that bring healthcare to us. Our insurance companies will try to lower their costs by keeping us healthier. But that isn't the total solution. You're right that it's going to be a terrible fight. It's not a fight that I'm confident we're going to win. I would give it less than 50% chance in the foreseeable future of being implemented here. That doesn't mean that most of humanity can't benefit. I believe that the systems that are now being created for efficient health delivery in India will be adopted by most of the rest of the world. Not Europe, not America, maybe not Japan, but 2/3 of humanity, I think China and many of the developing countries in Africa and parts of South America will adopt these, and that's a lot. If I can at least make some contribution toward that, I'll be happy. I'll be sad for our country, but I'll be happy for other people who are ill and need help.
I I think we'll cut it right there. Thank you very much, Bill.
You're welcome.